In part two of this lecture, I will cover breathlessness, shortness of breath, and respiratory assessment, but I will mainly focus on interventions for a client who's experiencing breathlessness or dyspnea. When we're looking at a patient in respiratory distress, we always function first on airway management, and all of you have learned the ABCs as you've moved through first year. Obviously, we can't help a patient to breathe unless they have a patent and clear airway. Now, there's different ways that we manage the airway. In some patients, particularly if they are unconscious, we can use an actual artificial airway device. That is something that you will see in lab, and you will talk a little bit more about in third year when we get into more of an advanced skill set. But an artificial airway can help to prevent the tongue from rolling back and also can give us a lumen that the patient can breathe through. Suctioning is another way to maintain the airway. Excuse me. So is coughing. With suctioning, we can typically suction in what's called the naso or oropharynx, so right into the back of the throat. So typically, suctioning is used for patients that can't clear their airway through coughing, or that may have really copious, which means a large amount, or thick secretions in the back of their throat or a little lower. We often see that in patients who may be dealing with respiratory infections or those that have, a weakened cough effort due to neurological decline or, issues with innervation within their chest. Now, a common way that we can position patients for airway management, particularly somebody that needs to have secretions drained so that they're not at risk for aspiration, is Sims position. I will be honest in saying that we don't use Sims position a ton. It is used to promote drainage and prevent aspiration, but as you see, there remains the risk that the patient is flat. Okay, so in Sims, they're prone and they will have their arm up and their leg bent with the pillow underneath, and then you'll just see how their other arm is just tucked to the side. The most common position for airway management, particularly someone in respiratory distress, is high Fowler's. So you can see here in this picture, this patient is in high Fowler's, and you'll see that the head of the bed is at 90 degrees. You'll see that semi-Fowler's is a term that's typically can be used between 45 and 30 degrees. Some times will refer to 45 degrees as Fowler's and 30 as semi-Fowler's. I find that sometimes it's easier just to really think about the degrees and how high you need your patient to sit up. And you'll remember when we talked about our stroke lecture a few weeks back, we talked about how a patient needed to be at a minimum of 30 degrees. And when you actually look at this angle, it shows you that your patient's probably a little higher than you think they are. So remember that on the side of the hospital beds now, there's a little ball bearing that will show you how many degrees the head of the bed is resting. It's also really important to give good mouth care. We do frequent suctioning. We make sure that we clean our patient's mouths out because that all helps with airway management. Now, as you remember from first year, here are the normal respiratory rates for adults. We know that typically we want to be between 12 and 20 breaths per minute. As you get more experience clinically, you'll start to find that as soon as your patients are getting around 12, you're starting to really think, are they sleeping or is something else happening? So it is important to count respirations, and I often like to count them for the full minute when I'm in clinical practice, just to really get a sense of what my patient's breathing is like. And it's very easy to do this at the start of your shift, just when you're first checking on someone within the room. You can just step back and watch them breathe, making sure that you're getting an accurate record. Pediatrics are a little different. So 6 to 8 years old, usually greater, like around 30, 1 to 5 at 40, and then we see in the little guys 2 to 12 months, 50 breaths per minute, and less than 2 months, 60. So just remembering that there are different indications for pediatric and adult clients when we're looking at respiratory rate. A healthy adult should have a an SpO2 greater than 92%, we find in patients that are critically ill and being resuscitated, I believe the new advanced cardiac life support guidelines recommend greater than 94. Sometimes patients have a condition called chronic obstructive pulmonary disorder, and we let their SATs run a little lower without getting worried. And I'm going to explain why this happens. It doesn't happen in every patient that has COPD, but there are a percentage of those patients that retain high levels of carbon dioxide in their body kind of at baseline. And so instead of relying on a lack of an increase in carbon dioxide to breathe, they rely on a lack of oxygen. And so if you give these patients that have these high CO2 levels that rely on oxygen to breathe oxygen, the body thinks that it has enough oxygen and therefore starts to suppress the respiratory rate. And this is all due to an adaptation of increased levels of CO2. So breathlessness or shortness of breath is graded at 5 levels. And this helps us to really kind of get a sense of how a patient is doing, particularly if they do have a respiratory condition. So grade 1 is breathlessness with strenuous exercise. So most of us would be a grade 1 at some point if we were exerting ourselves. A grade 2 is short of breath when hurrying on the level or walking up a slight hill. Again, that can be obviously a normal finding. A grade 3 means that they walk slower than people of the same age on the level or stops for a breath while walking at own pace on the level. A grade 4 is when they stop for a breath after walking 100 yards, and a grade 5 is too breathless to leave the house or breathless when dressing. So often patients that have chronic respiratory illnesses like chronic obstructive pulmonary disorder can be up to a grade 4 or grade 5, particularly when they are in end stages of the disease. And sometimes their breathlessness is so severe that they are malnourished because it's even difficult to eat. So this grading system is a nice way to really get some objective criteria around patients that are breathless. So when we're assessing breathlessness or shortness of breath, we always first look at the breathing patterns of the patient. Are they breathing slowly? Do they have hypoventilation? Are they breathing quickly with hyperventilation? Is there irregularity in their breathing? So for example, are they demonstrating Cheyne-Stokes respirations? So we really take a close look at their breathing pattern. We also look at use of intercostal muscles. Do they relax their shoulders, or are their shoulders constantly tense because they're indrawing air? Do they have to use their diaphragm to increase the depth of respiration? And often with that is you'll see more of an abdominal pull as they're breathing. And do they alter their rhythm of breathing as they're doing various things such as dressing or moving? And sometimes you'll see that we'll also kind of work towards enhancing the exhaled breath in order to help to clear the airways. And also there's a technique called pursed lip breathing where the patient will breathe through their lips like and really push the air in and out to kind of increase interthoracic pressure and to help with airway clearance. Okay. So as nurses, we're looking at these clues to tell us how bad the patient's work of breathing is. And then, of course, we can use some of these strategies to help them gain some comfort. So the most common respiratory exercises are deep breathing and coughing. And if you're working on surgery right now, you'll have seen this in practice because we use deep breathing and coughing to help clear general anesthetic from the lungs post-surgery. So it helps to increase the effectiveness of respiration. And when we're using it in a post-operative context, we do it every hour. It helps to decrease the risk of pneumonia in our hospitalized patients. And I find that I'll use deep breathing and coughing when I work on medicine to help patients that may have lung infections like pneumonia, help to keep their alveoli inflated. The other is huff coughing. And what I'll do is both of these are linked, and so I will post the links on your Cotter Online site so that you can actually see both of these exercises in effect. If you've been on the ward, you've seen the incentive spirometer. Okay, remembering that incentive spirometry is not about blowing into the spirometer. It is about really looking at inhaling in and measuring your vital capacity. Okay, so it really helps to promote expansion of the alveoli, and it helps you to expand and potentially clear your airways. And again, I've got a nice video here. I'll also link on Cotter Online so you can watch an example of incentive spirometry. The key reasons why incentive spirometry work is that it does provide incentive and it challenges patients to improve their breathing, so they actually have something to fixate on. It's goal orientated, so you can see here this is a pediatric incentive spirometer, so we have different measures of airflow, and if they can get the little bulb up, then they can score. And it is important that nurses do the teaching for incentive spirometry because it can be a bit confusing. And then here's another form of incentive spirometer as well. So we've managed airway when patients are having difficulty. And then the second thing that we do is we position. We have to remember that when somebody is struggling, that we have to put them in a position that conserves energy. We need to put them on bed rest, and we have to make sure that how they're positioned in bed allows for maximum lung expansion. And so that's why we tend to use Fowler's or semi-Fowler's position, because they're on their back and they're able to sit up, and they can even lean over onto their bedside table to help facilitate lung expansion in the posterior lobes. What's interesting is recent research shows that oxygen saturation increases with the good side down in side lying position. So that means if you had pneumonia on your left side, you would sleep with your good side, which would be your right side, down. So this increases blood flow to the good lung, thereby increasing oxygenation. And I have found that as a nurse, when patients do have are in a palliative form of care, and then you know that they have one lung that might be affected by cancer or they may be suffering pulmonary edema, you often find when you put them with their bad side down that you'll see oxygen saturation decrease and they'll struggle more to breathe. So what are common abnormal lung sounds? I've linked you here to the Easy Auscultation website. It's an excellent website to help you practice your lung sounds. And I really encourage you when you're in clinical practice to also be thinking about lung sounds and doing assessments on more than one patient, so you can really get a sense of what the lungs sound like. And one thing that's really important to do is to get used to the difference between like bronchial, vesicular, and bronchial vesicular sounds, because they sound like normal lung sounds, but depending on where they occur in the lung, it could be an abnormal finding. So we kind of in like pneumonia, for example, we might hear more of these bronchial sounds as they move through. So I'll link this as well for you so you can practice with the audio. Suctioning becomes quite important when we're looking at respiratory management, and I'd recommend that you get good at suctioning, or at least with the Yonkers suction, which is a blue hard-tipped suction catheter. Okay, and I'll just show you quickly what the Yonkers suction looks like here. We'll see if it will load for us.
So now we're going to review oral suctioning with the Yonker or handheld suction device. In most facilities, it looks a lot like this when it's a wall device. It's got the yellow vacuum wall piece, and then it has the suction apparatus attached to it with a dial to tell you how much pressure it's sucking, and then also a dial to tell you whether it's increasing or decreasing the level of suction. Then there's a red tubing hooked up to the canister that's attached to the wall. And there's an inner canister that you can change out, obviously between patients and when it's full. So you want to make sure that system is monitored and you can change it out if and when needed. And then to actually suction from your patient, you'll get suction tubing. So it's this larger bore thick plastic tubing, and it doesn't come with this attached. It's a separate a piece, but the Yonker section. So that's this handheld piece like this. It's a lot like the one that you use at the dentist when they give you that handheld suction to suck out the excess saliva. So if we set up all our equipment here and our patient is wanting to just hang on to this to help him clear his, he's expectorating, but he's having a hard time maybe spitting out the secretions, we can use this. This is just an oral suction, so it will just kind of go in his mouth. It's not intended for deep suction. It's just for in the mouth, and he can hold it and do it himself, or you could help him with it as well. So this one, the catheter doesn't need to remain sterile, just clean. So he can use it and then put it back in here to maintain its cleanliness when it's just sitting on the bed. So to turn it on, you would hook up all your apparatus, and there's an on-off switch back here. We already had it turned on, but when you do first turn it on, it's usually starts at 0, and you just have to increase the suction. So for an adult, it's roughly, for safe oral suctioning, 100 to about 150, but you'll see there's parameters here of green, yellow, and red for the amount or level of actual suctioning that you're getting. So you can hear it suctioning right away. You can ask the person to try it out, see if it works on their oral secretions, and you'll see them get sucked back into the canister. If ever you want to or need to clear the tube out, you can stick it into a sterile water container, water bottle, such as this one here. So you'd open up a new one and then stick it in there, and then you could clear it out that way, or oftentimes what we'll do is just replace the tubing if it gets kind of yucky and clogged, or it's starting to look a little clogged, because that will impair the level of suction it can deliver. So that's kind of the basics of oral suction device.
So a Yonker suction is used primarily for oral suctioning, and I know she suctioned primarily around the buccal cavity, but you can slide the Yonker suction a little farther back, so it hits the back of the throat, and often you'll catch a little bit more of the secretions back there as well. Nasopharyngeal suctioning is a little different, and it's a little more aggressive. So once you're signed off in lab,
before performing
when you're signed off in lab, you can do the Yonker suction, but nasotracheal and nasopharyngeal suctioning is something you will probably do more so in third year. And I'll just show you aspects of this video just to show you a little bit of the difference between the Yonker suction and the nasopharyngeal.
Tracheal suctioning. Make sure the patient has no contraindications to the procedure, such as a bleeding disorder, epiglottitis, or laryngospasm. Perform hand hygiene. Ensure privacy. And introduce yourself to the patient.
Good morning, my name is Erin. I'll be your nurse for today.
Then identify her using 2 identifiers.
I need you to verify your full name and date of birth.
I'm Sarah Kennedy, April 3rd, 1957.
Thank you.
Place a pulse oximeter on the patient's finger and leave the device in place.
Raise your head up a little bit so you can breathe a little bit better.
Help the patient into the semi-Fowler's position, or help her sit up. Put on a mask, goggles, and face shield if splashing is likely. Prepare your equipment by connecting one end of the tubing to the suction machine. Turn the suction device on and set the pressure to the lowest level possible that will effectively clear secretions. After checking the pressure by blocking the end of the tubing, place the open-ended tube near the patient within easy reach of your work area. Now prepare the suction catheter by opening the suction kit or catheter using aseptic technique. If a drape is available, place it across the patient's chest or on the overbed table. Fill the tray compartment with about 100 milliliters of sterile normal saline solution or sterile water. Open the water-soluble lubricant and squeeze onto the open sterile catheter package. Be careful not to touch the package. Depending on your agency's policy, you'll now apply either a pair of sterile gloves or a sterile glove on your dominant hand and a clean glove on your non-dominant hand. Use your dominant hand to pick up the suction catheter without touching any non-sterile surface, and use your non-dominant hand to pick up the connecting tubing. Attach the catheter to the tubing. To make sure the equipment works properly, suction a small amount of normal saline from the basin. Increase the patient's prescribed oxygen flow rate, instructing her to breathe slowly and deeply. Lightly coat 6 to 8 centimeters, or 2.4 inches to 3.2 inches, of the distal end of the catheter with the water-soluble lubricant.
Miss Kennedy, I'm going to go ahead and suction down your nose into your lungs to help get out some of those secretions.
Using your non-dominant hand, remove the oxygen delivery device. Ask the patient to inhale deeply. Use your dominant thumb and forefinger to insert the catheter gently but quickly into one of her nares as she inhales. As you insert the catheter, do not cover the catheter vent. Follow the natural course of the nares. Orient the catheter downward slightly. Don't force it. If you feel resistance, you've probably hit the carina. In that case, withdraw the catheter 1 to 2 centimeters, between 0.4 and 0.8 inches, before applying suction. When you're performing nasopharyngeal suctioning, a good general rule is to insert the catheter to roughly the same depth as the distance from the mouth or tip of the nose to the angle of the mandible. In adults, that's about 16 centimeters, or 6.4 inches. In older children, 8 to 12 centimeters, or 3 to 5 inches. And in infants and young children, about 4 to 7.5 centimeters, or 1.6 inches to 3 inches. If you're performing nasotracheal suctioning, insert the catheter about 20 centimeters, or 8 inches in an adult, 16 to 20 centimeters, or 6 to 8 inches in an older child, and 8 to 14 centimeters, or 3 to 5.5 inches in a young child or infant. In some instances, turning the patient's head can help you suction more effectively. Turning it to the right will help you reach the left mainstem bronchus, and turning it to the left will help you reach the right mainstem bronchus. Apply intermittent or continuous suction by placing your non-dominant thumb over the vent of the catheter for 15 seconds or less. At the same time, slowly withdraw the catheter as you roll it back and forth between your dominant thumb and forefinger.
Go ahead and cough for me.
Then encourage the patient to cough. Replace her oxygen device and instruct her to inhale deeply. Assess for the need to repeat the suctioning procedure, but don't perform more than 2 passes. Watch for alterations in the patient's cardiopulmonary status. When possible, allow adequate time, at least 1 minute, between suction passes to allow for ventilation and oxygenation. Rinse the catheter and connecting tubing by suctioning normal saline until the catheter and tubing have been cleared of secretions.
So as you see in that video, she started with nasopharyngeal suctioning. So nasopharyngeal suctioning is when you just go back into the back part of the oral pharynx, and you can do that coming up the nose, or sometimes in unconscious patients you can actually go in through their mouth on the side of their cheek, and then it will thread down. Now the second part that you saw was deep suctioning, and that's when the suction catheter actually went down into the trachea. Nurses aren't typically recommended to do deep suctioning. They will in some instances, but it is typically not normal practice unless you're in an area where that is commonplace. It can get a little tricky. You can end up with that suction catheter in the left or right main stem of bronchus of the lungs, and there are different things that can happen. You can cause vasovagal responses where you can make the patient extremely bradycardic. So you do have to have some knowledge around that before you're doing it. But in the context of year 2, yes, we can suction. If someone has secretions in their mouth or the back of the throat, we'll use the Yonker. And then once you go into 220 and you learn how to insert nasogastric tubes, that's also a really good time to start talking about how to insert a nasal suction catheter as well. So when do we suction? We suction when patients have are unable to clear secretions, when that is paired with decreased SaO2 levels, or if they have, a history of not being able to clear secretions and need to be suctioned, within periodic intervals. We always assess by attaching a pulse oximeter. We see what their SATs are, and then we listen to their chest for any adventitious sounds. And typically, you'll hear coarse crackles. We also assess after we suction to see if it has been helped. Complications, so like I said before, you can cause vasovagal reactions by eliciting the parasympathetic nervous system, so you can make them bradycardic and hypotensive. Sometimes you can actually decrease their saturations if you suction too long, and suctioning can be a very distressing thing for patients, and so we don't just, suction every few minutes. Like, we always have a reason to suction, and we make sure we have patient comfort. So in the last part of this lecture, I'm going to introduce you to some oxygen therapy and oxygen equipment. So the first thing that we always tell you as instructors is that any patient can suffer lung damage from high oxygen concentrations, especially if it's greater than 24 hours. And these signs and symptoms can include dry cough, chest pain, numbness in extremities, lethargy, and nausea. So I want you to remember that we don't want everybody to be on 100% oxygen. We want them to also be within their normal limits. Sorry, you probably hear my dog barking. So when to use oxygen therapy? So the role of the nurse is to always monitor the oxygen flow rate. We want to ensure that the nasal cannula, the mask, or the tubing is properly placed, and that we're assessing the condition of the mucosa and the skin as the oxygen therapy is in situ. It's important to always monitor the patient's response to the therapy and to really teach them around smoking and electrical sources that might cause them to have issues. So there's different types of oxygen delivery methods. Oxygen can be piped through the wall, and in hospitals you'll see it coming through the wall. You can also have oxygen in canisters, so it's portable. So if you have a patient that needs to move around for a test or is getting up to walk on the unit and they require oxygen, they can have a portable canister as well. Now what you see here is an oxygen flow meter. And you'll see it says oxygen on it. And at the bottom, there's a little silver ball. So here's 0 liters per minute. Here's 1, here's 2, 3, 4, 5. And then it comes up to 10 and then 15. So when you turn this up all the way, it's at what we call 15 liters flush, and that's as high as you can go on the wall before you actually need to, start using a bagger. Now, it's important to kind of remember that you can have very high flow oxygen as needed with this type of equipment. A lot of it depends on the device you're using because it will regulate the flow as you move through. The other thing is really important to remember is that there's often two adapters on the wall in the hospital. One's for oxygen and the other's for medical air. Medical air is for nebulizing medications, and it does not contain oxygen. It's basically the equivalent of room air. It's very important that you do not put a person who's supposed to be on oxygen on medical air, okay, because they won't be getting the required drug. This is just an example of some oxygen delivery methods. So here's an oxygen tank. Never let the tank fall. And it does come in many different sizes, and often a lot of them now are plastic on the outside with the tank in the middle. And this is just a short video. Let's see if it'll run here. Oh, it was supposed to be a short video on a procedure checklist. So all it is a little checklist for when you have someone on portable oxygen. I will find that checklist and we'll post it for you. Now, we're going to look at four primary ways that oxygen is delivered. The first is a nasal cannula. Okay. The second is a simple face mask. The third is a partial rebreathing mask, and the fourth is what we call a non-rebreathing mask. So all of you have probably seen nasal cannulas by now. So a nasal cannula is a little pliable plastic tube that is inserted in each nostril. And as you see, it comes up behind the ears on your patient, okay, and then around their neck. And this little adapter here can make it tighter. Okay, it's important to practice putting oxygen on. You'll have a chance to do that in lab. So a nasal cannula typically will go from 2 to 6 liters per minute. It is designed for low flow oxygen. Okay, as patients get sicker and their oxygen demands increase, then they require a mask instead. So here is an example of a simple face mask. It is typically for 6 to 10 liters per minute, and it can manage an oxygen concentration of 40 to 60%. So you can see here, it's just, they call it a simple mask because that's what it is, a simple mask. There's the elastic to go around the patient's face, and then see this white adapter here? This is what attaches to your oxygen tubing to take it to the oxygen outflow. Now, the only tricky part with the mask is that you must have a minimum of 6 liters per minute flowing through the mask. If you run the mask lower than 6 liters per minute, you'll cause carbon dioxide to trap in the mask and you can make your patient faint. Okay, so it's always an exam question I love to ask. You know, what is the minimum requirement for a simple face mask and why? So here's a better picture of a simple face mask. So you can see that you can tighten it on the side with the elastics. Here's where the oxygen tubing is attached, and then you can see that there's a little vent here as well. And then there is a metal adapter on the bridge of the nose to make it tighter for the patient. Something that looks like a simple face mask but isn't is a nebulizer. A nebulizer is for administering medications such as beta-2 agonists or bronchodilators that need to go into the lungs. And so what you do with the nebulizer is you put the liquid medication into this little chamber here, and you attach it to medical air instead of oxygen. And then what it does is it forms this really nice mist and nebulizes the medication so it can be inhaled into the lungs. Okay. Sometimes you may use a combination of air and oxygen. We use it with air through the nebulizer itself, and then what you do is you keep your patient's nasal prongs on in order to ensure that they have oxygenation. Okay, it is extremely important that if you have a patient on oxygen therapy and they are getting medication through a nebulizer, that you do not remove the oxygen. Okay, so as you see, we started out, we had a patient who required low oxygen, was on a nasal cannula, and then as their oxygenation needs increase, they went to a simple mask, and now if they were still having issues with getting their oxygen saturations up, we'd move to a non-rebreathing mask. So the highest concentration of oxygen delivered is 60 to 100%. So when I showed you that nice little oxygen flow meter a few slides back, this would be 100%. You could turn this all the way up. It has a one-way valve and it vents open for expiration, so it doesn't move in and out as the patient breathes. Okay, so it opens for expiration and they close for inspiration. That allows the oxygen to stay within the mask. The other type of high flow mask that you'll see is a partial non-rebreather mask. So it's vented a little bit differently, and you can see that it has a reservoir here as well. So as the high flow oxygen is moving, you will see this bag move in and out as the patient breathes. Sometimes this bag doesn't fully inflate, so you just have to be careful. Don't get worried if you don't see it moving. Then finally, if a patient is on a partial non-rebreather mask and they're still not doing well, then you may actually have to put them on a valve mask and bagger. So here we have a mask that can be adjusted to the patient. So here we are from a neonatal, pediatric, and adult mask. You can see the actual bagger, and then see how the bagger is attached to the oxygen tubing here. This gets attached to the wall, and you turn the oxygen up as high as you can. And a patient can breathe on their own if they have spontaneous breaths through a bagger. You just have a little thing here called a PEEP valve. And what a PEEP valve does is it maintains the pressure in the chest as they're breathing. And so sometimes you'll see the bag soften as they breathe. And sometimes the bag will make almost a snoring kind of noise, like as they're breathing in. Now, if a patient goes unconscious, then you do the breathing for them. So you fit the bag, the mask to their face. You put them in a recumbent position, so lay them flat, and you can bag them by squeezing the bag. Now, when we bag a patient, we don't bag quickly. We are trying to mimic their respiratory rate per minute. And bagging is a skill that you will really need to learn in lab. Your instructors will teach you how to bag because it is a component that we use in hospital with CPR, because we do not give mouth-to-mouth resuscitation without oxygen in the hospital settings. Now, what I wanted to show you is just for the sake of conversation. So this is content that you will cover in year 3, but you do need to know that there are advanced airways when patients become very, very sick. So when you have a patient that is getting bagged and they're not recovering, you may have to actually put an artificial airway in. So a common one that's used by paramedics and sometimes in the ICU is what's called a laryngeal mask airway, or an LMA. And basically, this tube, this fleshy area here, gets folded down. And then you have these aperture bars, and this goes into their actual airway. Okay, it's a device that is allowed to be inserted quickly. It seals off the connection between the esophagus and the trachea, and it allows for ventilation. This is typically only used by EMS and in emergency settings. Another tube that was used is not as much anymore, but it's called a King tube. It's a supraglottic airway. Again, we'll talk about this in year 3. This is put in emergency situations where you lose the airway. And what it does is it has a balloon that actually tamponades off the esophagus. You can see the esophagus here. and then that way, or sorry, esophagus is here, and then that way it allows for ventilation. Sorry, my anatomy is terrible today. Yeah, that's a trachea there. Okay, so you can see how here, oops, is where it would ventilate through. Okay, all right. I will bring a king tube in so you guys can see it. And then finally, this is a tube that nurses will deal with the most in hospital. This is an endotracheal tube. So this goes down the actual trachea, so it doesn't go down the esophagus. And then it's not held in place, but it's sealed with this balloon, and then this entire tube is taped. And then long-term airway management is typically accomplished through a tracheotomy, and in year 3 you will spend an entire class learning about these devices. So, review of airway management. So as nurses, what we really need to know is, how do we manage a patient who starts to go into respiratory decline? So we have Mr. Jones, he's 32 years old. He's presented to the emergency department with respiratory distress. He has a suspected bacterial pneumonia. Presently, he's on room air, but his oxygen sats are 84%. So let's decide to which equipment we should use first. So with Mr. Jones, the first thing that we would look at is obviously a nasal cannula. So by our nursing scope of practice, we can start at 2 liters per minute. Now, if his SATs do not come up, and they're still sitting at 84%, then we can call the physician. And what most physicians will do is they'll give you an order to titrate oxygen therapy to keep the oxygen sats greater than 92%. So instead of asking the doctor every time you want to increase oxygen by a liter, you follow a protocol. So you start with nasal prongs, and you can turn your nasal prongs up on the oxygen till it sits 6 liters. If the patient is still underneath 92%, then you switch them to a simple mask, and that can go from 6 to 10 liters. If they're still low on oxygen on 10 liters, then you can put them on a partial rebreathing or a partial non-rebreather mask and turn them all up to 15 liters flushed. Now, obviously, if a patient is decompensating while you're switching oxygen equipment, you would be telling the physician the entire time what is happening. In hospital, we work alongside with respiratory therapists in these types of situations and the high acuity response team. And they are part of a physician team where they're reporting back. And they also have the ability to put in advanced airways if the patient gets sick. So when you're in lab with your lab instructors in a week from now, they're going to take you through all this equipment and have you practice putting it on your patients and review when to use nasal prongs versus a simple mask versus a non-rebreather. So the patient teaching, I always teach them about how to put the mask or cannula on and why we're using it. It's important to know why patients are on oxygen and how their pathology is affecting their oxygenation. It's important to do oral and mucous membrane care. You should use a water-soluble lubricant when you're lubricating any type of equipment, especially in the nares. Years ago, we used to use petroleum jelly, but there is an issue with that being flammable if there was ever open flame. We also do oral care. Sometimes patients will be breathing through their mouth with the oxygens, and their oral mucosa gets dried out. We also want to decrease risks for infection. So sometimes we can do that by humidifying oxygen, making sure that they're in a clean environment. They're not putting their nasal prongs next to the commode or something that might cause them to get bacteria into their respiratory tract. And then, of course, decrease risk of fire injuries. Smoking is the biggest one with oxygen. I have seen an interhospital fire when I used to live in Edmonton with a patient who attempted to light a cigarette while on oxygen therapy. So it's very important that they are taught that they can't smoke while they're on oxygen. And also to remember that a patient smoking on the unit on oxygen not only puts themselves but the entire unit and the staff at risk for fire. When do we stop oxygen therapy? So we call this weaning. That means to remove the oxygen. It is a doctor's order to take them off oxygen, and we consider decreasing oxygenation or removing it when the patient's comfortable, if their underlying disease is stabilized, and that they show signs of stabilization. So that means they have a normal BP, a normal pulse rate, their respiratory rate is relaxed and within 12 to 20. They have pink skin, and their oxygen saturations are within the normal range. It's not uncommon for nurses to turn oxygen off on the unit and then to let the doctor know that they did do it. Because again, remember, oxygen toxicity is not something that we would like to see in our patients. Different patients require HOMO2. Often it's patients that need oxygen while they're sleeping, while they're moving, and most commonly we see it with patients with chronic or end-stage respiratory disorders that are prone to hypoxia. There is a process for receiving home oxygen. It needs to be ordered before the patient leaves hospital, and there are companies such as Vitalaire that will provide home oxygen equipment and then also provide access to oxygen tanks for patients as well. This is just a nice picture of someone with portable oxygen, so it's just showing you that they can still be active while they have an oxygen tank. The last part of this lecture, I'd like to talk a little bit around the concepts that we've covered in light of disease management. And what my plan is that when I come back, we'll have Thanksgiving off next weekend, and then the following week, I will spend the first half hour going over these concepts with you. We're going to talk a little bit about COPD, and we'll take some time this week to look over your concept maps. Oxygen is the only pharmacological treatment that's shown to increase survival for hypoxic patients with COPD. And typically, we give these patients low-flow oxygen. The only problem with COPD and oxygen is the example that I outlined at the start of this lecture around the notion of carbon dioxide retention. So the easiest way to remember is patients that have COPD that might be CO2 retainers. The higher you put their oxygen levels, so the higher their SATs go, the more decreased their respiratory effort will be. Because what's happening is you're taking away the hypoxic drive, which is the mechanism to make somebody with chronically high CO2 breathe. So for example, let's say you have a patient on oxygen at 10 liters per minute, and they have a history of COPD, and their respiratory rate is only 8, and they're really sleepy. Chances are, if you turn down that oxygen, and you get their oxygen sats between 88 and 92%, that patient will start to wake up and they'll breathe faster because their body needs that small shift in lack of oxygen in order to stimulate the respiratory effort. And I'll explain to you a little bit more what that looks like in COPD. Now, it's really important to remember that that's usually only about less than 10% of the population that have this issue with CO2 retention, but it is definitely something we teach you to look out for. Now, everything when we look at chronic illness comes back to primary health promotion. And so for these patients, it's primarily smoking that causes COPD. So we look at smoking cessation. Interventions can include counseling, setting a quit date, nicotine replacement, and drug therapy, as well as teaching and cessation programs and support groups. So one of the nice things about this program is you will get some experience in both community health and in year 3, looking at kind of interviewing techniques for risk factor motivation and behavioral modifications. So we'll look a little bit more around these primary teaching methods. Asthma is also another disorder that you're going to see while you're in hospital. Now, most of kind of cases of asthma primarily come through the emergency department because patients are in an acute state. So typically, because asthma is a chronic inflammatory disorder of the airways, your patients will have wheezing on presentation. So usually they start like breathing, like, and then you'll hear the wheezes on both inspiration and expiration. They have breathlessness, chest tightness, sometimes a cough in an attempt to try to move and shift the pressures in the chest. And we often see asthma more at night than in the early morning. So how do we control asthma? Asthma is basically elicited by an exposure to a trigger, and most commonly it's an environmental trigger, such as an allergy. We teach our patients a lot around self-management education with asthma, and one thing that you'll see on the study map chart I gave you is we'll talk a little bit around the role of a peak flow meter. A peak flow meter looks like an incentive spirometer, but it has a different function. It's actually measuring the vital lung capacity for a patient with asthma, and it allows us to understand if their asthma is in control or if they're at a moderate or severe risk of having complications occur. And so physicians use peak flow meters with nurses in order for patients to be able to manage themselves at home. So nurses teach the patients to use these peak flow meters. We also use pharmacotherapy primarily aimed around bronchodilation. So we call these drugs beta-2 agonist drugs, and what they're doing is they're trying to promote the opening of airways. And then of course we use anti-inflammatory agents as well. You'll also see that there are drugs for asthma and COPD are typically administered by inhalation, okay? And what we'll do is we'll show you the difference between a meter-dosed inhaler, which is like a handheld inhaler that you'll often see people shake and then administer. There's also dry powder inhalers that are typically circular and like a disc, and there's also the wet nebulizers, which are similar to what you saw in that one picture when I was introducing medical air. So here's an example of a meter-dosed inhaler, and here's a spacer. So the spacer allows a little bit more time for that medication, which is up here in this little silver tin, to actually hit the spacer and then come down. This is an example of a dry powder inhaler. So there's a common drug called Spiriva that we give patients, and you basically click it and then inhale it. And then we'll also take some time when I come back to talk a little bit about pneumonia, and I'll help you to differentiate the difference between a viral and bacterial pneumonia. We'll talk about the difference between community and hospital acquired. And then we'll go into signs of decompensation, which are really looking at that same principle of hypercapnia and hypoxemia that we saw at the very first part of this lecture. And then treatment really depends on the type of pneumonia that you have. Bacterial pneumonias get antibiotics. Viral pneumonias may be supported with an antiviral medication, but primarily both will focus on supportive care and maintaining the respiratory system. So the biggest piece is if a patient on O2 suddenly becomes confused, what should you do? We always check the source. So you're always making sure that they had their oxygen on, the oxygen's connected to the wall, and that it's running. We make sure that they're not showing any signs of oxygen toxicity. We take their oxygen saturation to make sure that they aren't starting to have clinical decline. And then once we are certain of what's happening, we may connect oxygen back up, we may increase it to treat SATs, or we may start to run other diagnostic tests. Because confusion can be related to hypoxia, but confusion can also be related to types of things like sepsis or having myocardial infarctions or urinary tract infections. So Always track the oxygen back, see if it's on, and if it's not, then we start our respiratory assessment looking to see if we need to put our oxygen higher. Perfect. Well, thank you, everyone, for your patience, and I hope that you got something out of this lecture. I will take time the next time we are together to look over these slides and to look at the pathology in more detail. I've also marked your quizzes. They will be up on Moodle shortly tomorrow. I just need one of the IT folks to just give me a column on Moodle so I can enter the marks. What I have decided to do is we will have quiz 1, quiz 2, and quiz 3, but I am going to offer a bonus quiz, which you can do to replace any of the marks in any one of the 3 quizzes. So I'll talk a little bit more about the redemption quiz as we kind of go through things. I was happy with the quizzes, but I did spend a lot of time giving you feedback on how to study because the entire purpose is to focus in. And I think based on how you did on these initial quizzes, I would like you to have another week and to take home the next quiz again on your own, because I do think we need a little bit more work on just kind of helping to make the links between where we're studying and how we're answering the questions. Okay, I hope everyone has a great week, and I really hope I haven't put you at a disadvantage by missing tomorrow. But do take care, and I will see you guys after Thanksgiving.